MDS Hub podcasts, brought to you by Scientific Education Support.
Hello and welcome to the MDS Hub podcast. Today we'll be hearing from Uwe Platzbecker from the University of Leipzig Medical Center in Leipzig, Germany.
Hello everybody, my name is Uwe Platzbecker from the University Hospital in Leipzig in Germany. Welcome to this MDS Hub here, and my topic today is to discuss the potential hematological toxicity which actually is induced or observed with a combination of azacitidine and venetoclax. I had the honor to present a poster on actually the management of this kind of toxicity from an ongoing phase 2 study, which actually investigated azacitidine at the standard dose of 7 days with venetoclax. The background, of course, is that many of our high-risk MDS patients are already neutropenic at the time of diagnosis, so they are prone for infectious complications. And with the introduction of azacitidine, I think many of us have witnessed that patients actually sometimes have worsening of the neutropenia, especially during the first 2 or 3 cycles. So now with the introduction of venetoclax on top of 7 days of azacitidine, this neutropenia and also thrombocytopenia is actually aggravated, which of course renders the patients at an increased risk of infectious complications, morbidity, and mortality. So the nature of this MDS, high-risk MDS study of AZA and venetoclax was at the very beginning to use the same combination and also dosing of azacitidine and venetoclax, which is currently approved in elderly AML patients, which is azacitidine for 7 days and venetoclax at a dose of 400 milligrams as a continuous approach. So in the phase 1, phase 2 part of the study, actually, the data were generated that this may be too toxic for high-risk MDS patients because there were a lot of infectious complication and even death as a result of neutropenic sepsis. So since then, the dose was actually modified to 2 weeks of 400 milligram of venetoclax in combination with 7 days of standard dose azacitidine. So the nature of the poster I presented was actually generated and taken from the phase 1, phase 2 study, where actually investigators could dose modify the azacitidine or venetoclax in case of neutropenic complications or prolonged neutropenia or infectious complications, but also platelet toxicity. Thrombocytopenia was part of the strategy. So there was strategy number 1, which was actually to reduce venetoclax or azacitidine, and the option number 2 was to reduce azacitidine first, followed by venetoclax. Of course, this was at the discretion of the investigator, so this is not a controlled randomized part of the study, so it's a retrospective observation. And what you can see is in the patients analyzed is that the this kind of dose modification was feasible in all of the patients. Also, it did not affect the response assessment, but also the responses observed with these patients. So the overall response rate exceeded 80%, irrespective of this dose modification strategy. There was a slight imbalance with regards to the use of G-CSF, which was allowed and was possible in both, let's say, arms or both procedural options, so option 1 or option 2. And also infectious complications, fever and so on were also not different between the both strategies. So to make a long story short, I think the jury is, of course, still out what is the best strategy, but I think both of them seem to be tolerated by the patient. They may not weaken the response, which can be achieved, the very high responses, which can be achieved with this combination. And the study was therefore also very important because at the moment, the phase 3 Verona trial, which actually investigates azacitidine versus azacitidine venetoclax in a randomized fashion in a phase 3 study, has started, and this study aims at registering the azacitidine venetoclax combination for high-risk MDS patients, so very important study. And of course, in this study, in patients undergoing hematologic toxicity or infectious complications, of course, you have to define a strategy, what is actually, or what has to be done in case of this toxicity with regards to the reduction of either azacitidine or venetoclax. And in this study, in this prospective, still running study, the concept is to reduce azacitidine first. And the reason for that is also that it's a placebo-controlled study. So you have either placebo or venetoclax. So dose reducing placebo may not result in any changes of the hematological toxicity. So therefore, azacitidine is reduced first. And this is actually taken and based from the analysis I was able to present on behalf of my colleagues at the EHA. So I think valuable information, also clinically valuable information right now for doctors and hematologists who may already treat patients with this azacitidine and venetoclax combination. Thank you very much for listening. And if you have questions, send me an email. I'm happy to respond.
Thank you for listening to the MDS Hub podcast. We would also like to thank our supporters, Novartis and Bristol Myers Squibb.
MDS Hub podcasts, brought to you by Scientific Education Support.